So ctDNA and minimal residual disease testing are important as they allow us to follow our patients for their risk as well as the development of a possible recurrence. With ctDNA, we're able to evaluate specific signatures that the patients harbor and personalize the tumor marker that we follow to be able to see if a patient's disease has come back or has never gone away after surgery. It allows us also to determine any patients that we might need specific chemotherapeutics, targeted therapies, or immunotherapies versus patients that we can have active surveillance on. Cygnetera is an assay that we use in the clinic to evaluate patients for the risk of tumor disease recurrence or tumor disease risk aversion. And the reason why is that when we evaluate their gene signatures, we do so on whole exome sequencing, meaning that we take the patient's entire gene signature and evaluate for high-ranking genes. Those high-ranking genes are a personal stamp as to the patient and their disease process. When we evaluate those after surgery, we can see if the patient is high risk or low risk for having a disease recur or a disease that was removed by surgery completely. Over time, we can follow these ctDNA analyses and determine if the patient has had a possibility of tumor recurrence or they continue to be a patient who is in remission. It allows the clinician to have another tool and evaluate the need for implementing therapeutics or continuing active surveillance, allows the surgeon to understand the extent of their resection, and allows the patient to understand how well they're doing post-surgery or post-chemotherapy. The Expanded Access Program has permitted us to evaluate patients off-site. Patients are obtaining both blood and germline DNA sequences from at home through mobile phlebotomy. And we're doing it now for all patients in gastroenterology who have specific cancers. Although there's no data currently to say that would work in other GI types outside of colorectal cancer, these are the available tools that we have to evaluate our patients from afar. Although decisions aren't being made specifically on this information, it gives us another piece to have in evaluating our patients when we're not able to see them directly. The virtual ability of us to run tests in parallel while our patients continue on treatments or on active surveillance is another bonus as we can continue to treat, but also have the ability of acquiring information during that time. Recently, I had a patient who had a early to mid-stage rectal cancer. The patient had a stage 2A tumor. At the end of the day, there's always this fine line of should we treat this patient or should we not? And we always evaluate for high-risk features that are found within the tumor. Things like lymphovascular invasion, perineural invasion, positive margins, lymph node status. The patient had some high-risk features, but was very timid about coming in to get chemotherapy and radiation during the COVID outbreak. With the help of the ctDNA analysis, we could determine that the patient actually had a positive signal. And this provided us with another piece of evidence to support using chemoradiation at this time, understanding that the risk for COVID at the cancer center that we have is being de-risked through screening procedures, no visitor policy, and evaluating all clinicians and participants in the infusion of therapeutics. Therefore, the patient was able to move forward with therapy, confident that it was the right decision, but also understanding that we were de-risking her situation.